Welcome, all of you, to the ERC webinar. My name is Tino Greif. I'm a retired professor of anesthesia and education, medical education, and I have the pleasure to moderate and guide you through this webinar on in-flight emergency with Ahmed, who at the moment stays in the UK. Ahmed.
Thank you very much, Tino. Such a pleasure to co-moderate this webinar alongside yourself. My name is Ahmed. I am an emergency medicine resident doctor originally from Egypt, currently training in Scotland. I'm also one of the young ERC committee members and about to finish my master's degree in resuscitation medicine at Queen Mary University of London. Today, we have more than 1,000 registered participants. How exciting. So a little bit of housekeeping before we move on to the rest of the introductions. This webinar is going to be recorded, so you can come back to the recording later on if you wanted to catch up with a piece of information or something like that. We want you to be engaged as much as possible in this webinar, so please share your questions and comments via the Q&A function, not the chat box, because we cannot see the chat box, so only the question and answer function, please. Without further ado, it gives me a great pleasure to introduce Professor Camilla Mittelman, who is an anesthetist and a professor in emergency medicine at Ulm University in Germany. Camilla is an expert in pre-hospital emergency medicine and a very esteemed researcher in resuscitation telemedicine and emergency medicine, and a very, very dear friend. Welcome, Camilla. With more than 15 years of pre-hospital and hospital clinical research, education, and quality improvement experience, Dr. David Piran is joining us today. David is an advanced care paramedic from Czech Republic, who is also a senior researcher at Charles University in Prague. He is also a fellow of the ERC. It's such a pleasure to have you today, David. We are very keen to listen to your introduction, and the mic is yours.
Thank you very much. Welcome, everyone. We are going to talk about in-flight emergencies, resuscitation, and it's quite an interesting topic. We will start with the evidence behind, and I will be honest here, we will not present the new guidelines and the new chapter, despite that some of the information we worked when we were working and writing the chapter of special circumstances. That's why the evidence update we made is from 2021 till January 2025. We went through the ILCOR COSTERS, which means Consensus on Science with Treatment Recommendations. And for some topics, like this one, we went into the scientific databases and we specifically looked on the topic of in-flight cardiac arrest and microgravity resuscitation. As you can see the flow charts here, we screened 12 titles, later on 4 abstracts out of the 12, and we selected 1 publication finally into the chapter. For the microgravity resuscitation, 2 publications finally were selected. So basically, we will today be talking about those articles, those evidence behind that you can later on get into and see maybe more information and go more in depth. So let's start with the in-flight.
Yeah, so my first question for Camilla, who is covering this part, is how often are emergency in commercial flights? What do you think?
So luckily, it's not going to be on each flight you are attending. However, when we think that there are 4 billion passengers each year traveling globally, this is a high number. And we have seen in the last couple of years that passengers who travel are oftentimes getting older, and there are more passengers with pre-existing illnesses. So the likelihood that some kind of emergency will occur during the flight is quite high. But how high is this number? Well, it's quite hard to say. Luckily, we have found a meta-analysis, and this meta-analysis tells us this is roughly 18 in-flight medical emergencies per 1 million passengers. But when you see it at the confidence interval, you can see that this number differs between 0.5 and 53.4. Why is this number so diverse? Why are there so many different numbers out there? Well, we have to say that when we count the incidences, we have different registers we are looking at. Some airplanes, some companies registers the emergencies with the personnel working on the plane writing down if there was a medical emergency. In other cases, the studies just mentioned those emergencies which were so urgent that they contacted a ground-based medical crew. So there's a difference between that. And what is a medical emergency or medical incidence? If someone eats something during the flight and then has some itchy skin, well, that is kind of an allergic reaction, but is it really an emergency or not? So the definition of emergency differs. Coming to a closure, it's hard to say how many emergencies there are, but we think that there are roughly 18 per 1 million passengers. Luckily, the mortality is quite low with 0.1 per million passengers. There's also a registry data from the Lufthansa, which is one of the aircraft operators. And then they tell us that in their registries, they had 1 in 10,000 to 1 in 40,000 passengers. And they say that roughly we have 1 incidence per 24 intercontinental flights. And when we look at the data, we also see that the incidence differs between long distance and short distance flights. I mean, if you travel for 12 hours or more, the likelihood that something will occur is higher, especially if you take into account that all the pathophysiological changes you experience during the flight will be more likely if you travel for a longer time than if it's just a 1 hour trip.
Camilla, you said there are minor events, medical events, but if they are really tough emergency, how often do they have to go down? How often are they landing with an emergency? Well,
there are few data on the detours and the diversion. Mostly the data we found is that the main reasons why the crew decides to divert the plane is for cardiovascular or neurological events, mostly cardiac arrest, and oftentimes myocardial infarction or stroke-like symptoms, where you really, really want to get the patient as fast as possible to the hospitals. And what we found is that roughly 11 diversions per 100,000 flights. To give you a relation, what's 100,000 flights? Because, well, I have a problem imagining, is that a lot of flights? Is it not so many flights? We can roughly say that there are roughly 600 flights from Heathrow Airport each day, just to get you an estimate of what if 11 diversions is a high number or not. And that differs between different flights, if it's, again, long distance or short distance. In short distance flights, people are more bound to just get to the destination they planned to get. And if it's a long distance flight, the likelihood that they will decide to descend earlier, to choose a different landing site is a bit higher. But I guess David has some inside information on that because he knows someone who is doing that as a job.
That's true.
David, do you have information? What triggers, so what are the points when the flight is going down, landing because of an emergency?
It's quite interesting because my brother is a pilot, is a captain of Boeing 737. And when we discussed this topic together, the question is that different companies across Europe have different strategies or rules when to divert the plane. But what Camilla said is quite interesting, especially in cardiac arrest scenario. the landing needs to be as fast as possible because we can't do much on board of the plane. So when we see the articles, the evidence behind, the authors were operating with 20 minutes interval that you can land, which is probably possible among Europe, where the net of the airports is quite good, and the pilot is able to choose the nearest airport and in 20 minutes descend and land with the plane. The question is, 20 minutes, it's quite a long interval, and it's from the decision to land, it's 20 minutes, but we still need to count the minutes before. So when someone collapses on board, the other passengers need to alert the cabin crew. Then the cabin crew needs to find out what's happening. Then probably, and we will talk about it more, the public announcement will happen. And then the decision will go from the crew, for the cabin crew, to the pilots. And then the captain needs to decide. And there are rules for some companies that first the captain needs to contact the ground medical personnel, and the decision is based on the ground medical personnel, not only on the captain. So that's the difference between the companies. So roughly it can take from 30 to 50 minutes from the incidents till the landing, which is a long, long interval.
But then it's a huge difference in between when we are going to our topic, CPR, cardiac arrest, if somebody has a cardiac arrest on the plane or at the airport.
Oh, yeah, that's true. If you have to choose where you want to have your cardiac arrest, you'd better choose to be at the airport, because the likelihood that you are going to survive with good neurological outcome is far higher. So when we look at the data, which was presented by Chatterjee, they analyzed the population of passengers traveling either to Seattle Airport or being at the Seattle Airport. And they concluded that because people were traveling to Seattle Airport, they are probably the same people. So they don't see a lot of differences between the populations. And then they looked at different aspects. And the first one was bystander CPR. And you can see that bystander CPR on a plane was 88%, which is amazing. We don't have that high numbers in usual cases when we have cardiac arrest occurring at home or in residential areas or at the marketplace. But in a plane, there are so many people, and the likelihood that someone notices that the person sitting next to you is unconscious and not breathing normally is quite high. I mean, you have to distinguish, is this person just sleeping or if it's unconscious and not breathing normally? But once you've got that done, the chance that someone sitting next to this person knows how to do CPR and is willing to CPR is quite high. So we have a very, very high number of bystander CPR. And since there are many planes which have an AED, the likelihood of bystanders applying an AED and using it is also very high with 71%, much higher than we see in normal situations, and higher than at the Seattle Airport in the study. And when we just look at those two numbers, bystander CPR and AED applied, we would assume that those people who are at the plane might have a higher chance of WASC and survival to hospital discharge. But we see that WASC is much higher at the airport, and survival to hospital discharge is nearly 3 times higher when you have the event at the airport. So there's more into the outcome, and there are more factors influencing the survival than just bystander CPR and AED. And when we look at other airports, we can see that these airports are places where the chain of survival really works quite well. We have an analysis from Denmark, and they compared cardiac arrest occurring at the Copenhagen airport with all the other occurs occurring in Denmark, and they have a very great Danish occur registry. And we can see that although the bystander CPR rate was lower, and I mean, look at those amazing data from Denmark, they have a bystander CPR rate of nearly 90%, which is much higher than in other countries. We can see that the bystander defibrillator rate is very high in Copenhagen Airport, and the WASC rate is nearly 80%, and survival to hospital discharge is more than 56%. And the authors conclude that this is also due to the fact that we have a high number of AEDs, and they illustrate that with a picture showing us the AED locations at the airport. And one can see that there were several, and that was back in 2021. So the number might be even higher nowadays.
Camilla, there's an interesting question on the chat. How long does it take at the airport, the response time at the airport? Any number? Do we know how long it takes at the airport until help is at the person?
Yeah, most airports, when we look at the big airports, have medical crews on the airport, and they are trained, and they are often paramedics. And in some airports, we also have physicians there. And they will try to be there as early as possible. And they have quite a lot of equipment with them. So we can compare them to the pre-hospital emergency system outside the airport. I think that the numbers differ between the different airports because they are built quite differently. I mean, if you have traveled between different airports, you know that the architecture between those airports differs. So it makes it easier for some emergency teams than for others. But we don't know exact numbers for each airport. And there was one study released just last week. And in this study, they compared all airports in the United States with non-airport, non-residential locations. And they also found that the WASC rate was much higher at the airport than in other non-residential areas. And Schechter explains that he postulates that the chain of survival is really strong at the airport because we have so many bystanders. The chance that someone knows how to do a CPR and is willing to do CPR is quite high. And we have a lot of defibrillators there. So they conclude that the airport is an ideal place to test the chain of survival and to see which links are strong and how we can make them even stronger. And those findings we have from the airports, we can choose them and take them to other settings as well, maybe to train stations or to other non-residential areas.
Very interesting numbers. Thank you very much, Camilla. It's really good to see all these growing numbers, and taking you back to the plane, inside the cabin, there is relative hypoxia. How does that influence the quality and the performance of CPR?
Well, we have to say that the partial pressure of oxygen is lower when we are up in the air in the plane. There are different numbers, and I think it differs if you are doing a short distance or long haul flight, and also differs which route you are taking if you are transatlantic and where exactly you are. But what we can see as a general remark is that the partial pressure of oxygen is lower. So some people tend to do some hyperventilation and tachycardia. So that means for those who are performing resuscitation, your endurance is likely to be a bit lower. So you might want to change earlier and not continue chest compressions for 2 minutes. But please be aware that there are other people there who might be able to help you. So please ask them to support you. And we also have to think and to consider that the dry air is problematic for some people who are there to help them. And you as a rescuer might also suffer from sleep deprivation, especially if you're traveling long distance and not going there on vacation, but on a business trip.
Yeah, and another story is when the pressure in the cabin drops down, and that will affect not only the patient but also the rescuers. So there's another thing that we might think about. When the pressure drops down, it takes some time until the plane goes to the normal altitude with the normal pressure and normal oxygen concentrations.
Maybe in the meantime, some questions from the audience. If somebody is asking what to do with defibrillation outside of the airport, we will not discuss this in this webinar, but if you're coming to the ERC conference in October, you will get a lot of information how to improve defibrillation and bystander rescue. The other stuff is maybe for David. Somebody's asking, if you are going on board, should you tell the crew that you are a physician to save time?
Actually, there are some companies, I'm aware that Lufthansa is doing that even on your cabin bag, you will get the physician sign. So some of the companies, I experienced maybe once or twice giving first aid on board. And for example, Emirates, where we did it for the last time, they already, for the next flight, they were aware of us that we are with the medical knowledges or education. So when we were boarding, they asked, so if anything happens, can we ask you? I said, yeah, why not? So they were aware, and maybe there are some register also for Emirates. So yeah, there are companies with the registry you can opt in.
And some companies also offer a bonus for those who register. So you might get to choose your seat, and you might get a better seat if you say that you're a medical professional.
Really?
Yes. So you might want to do that. And what we have to say is that medical profession, well, the definition differs in different countries. And in some countries or in some companies, someone who's accepted, in others will not be accepted. Some just accept physicians, and others also accept paramedics, nurses, and all other different kinds of medical professionals.
Mm-hmm.
Please don't be disappointed if you have a medical qualification and the flight crew will tell you, well, you are not a physician, we don't want you to help. This might be a company policy.
Okay. There's another topic which lets a lot of people are asking, are AEDs on the plane? Where are these? How can we use this? What is the equipment? With what can we expect on board?
Yeah, well, we have to say that not all companies have an AED with them. There was one study by Hinkelbein, and he found that only 65% of all airlines had either an AED or an ECG. There are some regulations for some countries. For instance, all flights in the US need to have an AED, but those regulations do not adhere to every country. And the medical kits they offer differ between, for instance, North America and Europe. And if you have a transatlantic flight going from Europe to North America or vice versa, those companies might have equipment for both settings, for the European standard and for the North American standard. But not all countries request a plane to have an AED with them.
Especially for the long distances, like under 2 hours, even for the Europe, there is no need to have the AED on board. But again, there are some companies that once they buy the AED for a long distance and then the plane is doing short distance, they will not remove it, so it's staying in.
Mm-hmm. Anything else on board? What can help us in in saving life or attending people?
Whether they are bound to have first aid kit and a medical kit, those differ. There was one analysis by Oliveira, and he asked different companies and different flight organization to tell him what they have on board. And we can see that out of all those who answered, nearly each one had adrenaline with them, which is a good thing, but not everyone. And most of them had also things like antihistamine to treat, for instance, someone who has problem with the meal they were having at the plane. And there are quite a lot of companies which also have, for instance, bronchodilators, if someone experiences shortness of breath, for instance.
So beside of cardiac arrest, which is obviously very heavy, what is quite often, so what are our usual medical problems? This maybe was the slide before.
Yeah, that was the slide before. The top non-arrest emergencies. Again, this was from the meta-analysis done by Borgostyn Nascimento. And he saw that syncope was, and pre-syncope was the most common emergency. Additional to that, there were quite a lot of gastrointestinal complaints, nausea and vomiting. And I think if you've ever been on a plane, you probably would have seen someone who tells, oh, I'm not feeling so well. And that might be due to just a traveling sickness, or also due to having eaten something when you started with the plane or something like that. Then there's quite a lot of respiratory events, shortness of breath, for instance, people who already have problems, for instance, COPD, and now experience the relatively mild hypoxia and might not cope well with that. There are also neurological disorders with stroke symptoms or stroke-like symptoms and seizures. And cardiovascular events, which are mostly chest pain and arrhythmias.
It's another question or a topic of questions. The crew, I know the crews are trained in first aid and CPR. Essentially, in our area, they are still lay providers. As a professional, you are a healthcare provider. Then you count as a professional in the CPR area. Any information for us how these crews are trained? How often, at which level? Are they a level like a first responder?
Again, this differs between
But
the companies.
In
It
general.
differs a lot. It differs a lot, but basically the basic CPR, the BLS level, and how to deal with other situations and how to manage the situation on board when there is a physician or other healthcare provider. So they are able to communicate. The thing is the ground medical team that they can reach for support. And even when we were dealing with the situation on board and we had a physicians with us, when we say, okay, we are going to do this and this, the crew needs to discuss our approach with the ground medical crew and get their permission for us to continue. So we were not allowed to do anything until the situation was approved by the ground medical crew. So yeah, it differs a lot, but basically the crew is at least with BLS skills.
There's a question, if there's really a cardiac arrest, where are you going to do this CPR? Is there enough space? That's really the direct question to do so.
It
Would
is.
you like to start or?
Yeah.
It is quite crowded, yeah.
Yeah,
Go ahead.
it's already written in the 2021 guidelines. So we will put the patient into the galley, into the idle, and one of us who is doing the chest compressions will be next to the seat in the leg space in front of the seat. And if this is not possible, then the over-the-head CPR is also allowed, mentioned in the guidelines. So yeah, even in the small planes, it is possible to do it with the proper positioning of the patients.
There's a question about mechanical devices. I never saw this on a plane.
We are not aware that there is a single company having that on board.
Good.
Right, so thinking about all that, the first 60 seconds after the call, so there's an announcement that there's a cardiac arrest on the plane. What happens? What's the script?
Dave, would you like to go ahead because you've already experienced it twice?
So yeah, basically it's up to the cabin crew. So first they need to do the public announcement on board. If there is any physician or healthcare providers that can help them, they will get a notice into the cockpit. So the pilots are aware that there is something happening. They can't, in most companies, they can't open the cockpit. So they are still closed there for security reasons. So they will get the announcement and they will wait for the cabin crew and their information. And again, it depends on the company and their approaches and rules. So in some companies, the pilot, the captain can do the decision by their own if he wants to divert or if they continue until the final destination. Or some companies have the rule that they need to contact the ground medical crew and the decision then lies on the ground with the crew. So the 60 seconds is public announcement, start CPR as soon as possible, and the cabin crew will, if it's cardiac arrest, then the cabin crew will come with the AED and they will provide the AED as soon as possible. So yeah.
And if you were on board and asking yourself, shall I respond or not? Will I have some legal issues if I respond? You have to consider, are you in a position to do that or not? If you've already consumed quite a lot of alcohol because you're on vacation and just celebrating, you might want to reconsider and just see if there's someone else who's going to attend it. And if there's no one else, think about attending the patient or not. There is a possibility in most cases to contact the ground crew, the ground medical crew, and we would encourage you to do that. So the decision doesn't lie only in your hands, but also in the hands of the others. There are quite a lot of people who are afraid of legal issues. Well, we also have the problem that this differs between different countries and different companies. Sometimes the legal issues are based on where the company is stationed. So is this company from US or not? Or is it from Europe? Sometimes it depends where this plane started. Did it start in Europe? Did it start in another country? In most cases, if you don't accept any money from the patient or the family, you should be fine. But really, really think about accepting some gifts from someone, because then it's not part of the Good Samaritan Act.
Maybe we can close this session and then move forward, but there are still some questions. People are telling us maybe major problems is allergic reaction and diabetes. Any information on this? Do they have treatment for this on board?
Yes. For allergic reactions, for instance, we have the adrenaline, and most companies also have antihistamines, and then they have some oxygen. So we should be fine with basic treatment. And those who have diabetes, everyone recommends them to take the usual blood glucose measurement stuff with them. And we would, as the ones who approach the patient, ask them, do you have like a glucometer with you? Can we use that? Or do we need to fetch it from the aircraft?
Just one, sorry, just one minor comment. practical comment, because one of the situation I experienced on board was hypoglycemia with the insulin pump under the hijab. So the thing we experienced was that the glucometer that they used on board comes with different units. And we were absolutely not sure the calculation. So it comes with milligrams per deciliter, and we are using millimoles per liter. So, and you have no Wi-Fi on board, maybe, so you can't double check it with Google. And so it's quite important to know what we are using. And another thing it was that we started the defibrillator on board and the monitor and defibrillator, and we were the first ever who turned it on. So we need to go through the basic settings and put everything to be able to use it in real life.
Good. Let's move on, and then we might have even time at the end to discuss other points of this. Ahmed.
Yes, so we still have loads of questions. We'll try to accommodate those later on. But moving on to the second part of this presentation about microgravity, how does it work?
Yeah, it looks strange that we are talking about CPR in microgravity, but basically when we went through the numbers from the history, so we see the number of people reaching space in really old history and even modern history. The thing why we decided to incorporate that is the new era of commercial flights into the space. And we see that it really rising, or maybe not rising, but normal people without special training and without really good health can reach space or microgravity environment. So that's why we decided to work also on this topic. And how it works, who knows? It never happened before. So we don't have any reported CPR on human in space. So every evidence we have is from some parabolic flights and analog studies like underwater, and consensus based on simulations.
So what would you do now if there's a cardiac arrest in microgravity?
There is a European guideline from Germany that already try to incorporate all the evidence into one. So the recommendation is to begin with the Evet Russomano technique. You can see it here on the picture. So we will just hold the patient between your legs and start the chest compressions. We will probably discuss later on the effectivity of those techniques, but this is the first you can try when you are floating in the space. Then if it's feasible, or if it's not working, you can do the reverse bear hug. But the aim of the crew might be to secure the patient on the crew medical restraint system and to start like real CPR, to also restrain the rescuer and start conventional CPR. But if you can only secure the patient, then you can use the handstand method if the situation permits, which is here. You will just need a closed space, which so far all the spaceships are. And you have the patient restrained, and you will just use the opposite wall and start the compressions on the chest of the patient. But yeah, as I said, it's a theory based on simulations, and similar environment not so far tried in space.
And then use of AED, airway management, the same as elsewhere?
Yeah, it's almost the same. So when we transport the patient to the crew medical restraint system, we can provide a standard ALS. And of course, it looks like the most feasible thing is mechanical CPR. So mechanical chest compressions, which is also, it probably will work even in the microgravity. And of course, self-adhesive pads, which are part of AEDs, and the laryngeal mask, because we probably not have any anesthesiologist on board of the spaceship so far. So LMA can be used also by trained cosmonauts or other crew members. So yeah, the rest is almost the same except of the gravity.
So to be politically correct, we use a supraglottic airway and not a specific product from a
Yeah,
company.
yeah.
Okay, interesting. And if these approaches to CPR are impractical, are there any new or no equipment alternatives?
There are some published other ways how to do CPR. One is quite similar to the one that can be used on board of helicopter by HEMS crew, done by the elbow. So just you have the patient on your knees doing the elbow CPR, and or the patient is lying next to you and you just pressing with the elbow because you have in confined space, you don't have enough space to do conventional CPR. So this might be also a reasonable approach. But again, it's only tested in simulation environment or underwater environment. So yeah, there are some other techniques that can be also used, but be honest, the quality of CPR decreased a lot with all of these techniques. So it's probably better than nothing, and you can try, but the quality is low, quite under the standard we want to see.
But
So
David, excuse me, before we said it takes 20 minutes for a plane to land. How long does it take in outer space to come back to Earth? And then how are you going to perform CPR in this time?
It's quite interesting questions, it depends. If it's just parabolic flight, when you lose gravity for several seconds, minutes maybe, then it's like the in-flight emergency and you can land in 20 minutes. When you are on the orbit or suborbital place or on the International Space Station, we saw it in last month that it took them like 2 or 3 months to get there with another ship. So as one of my colleagues said, then the patient is dead. That's the only thing we can do with it.
Okay.
So-
So in summary, what can we expect from outer space?
So in summary, I'm actually looking forward because the future will show us how the commercial flights will be popular, and if this shift in our minds will promote more research on this topic in the future, and how the companies, and I will again not name any, will incorporate these emergencies into their standard operation procedures and how they respond to the needs of having the plan when something is going wrong. So yeah, the research is needed.
To Camilla, because there's a question which I think we should clarify because it should be clear by now. The question is why, again, what is the difference to the flight emergency with oxygen, partial pressure, and why does this affect outcome of for example, cardiac arrest? This was still unclear for persons who are asking.
Yes, thank you. So there are some people who have already pre-existing illnesses with their lung or with their hearts, and they might not tolerate the conditions during the plane ride as one who is healthy. And so the likelihood that they experience a cardiac arrest is a bit higher. And we have to be aware that those who perform the chest compressions, the rescuers, they also might have problems with the reduced oxygen levels and with the pressure levels. So it might be that people who usually have a very, very high performance when doing CPR have not as high a performance as they usually have.
And is it correct that on a commercial flight, this is the partial pressure of oxygen is likely as on a mountain of about 2,000 meters?
Yes, that's roughly the number.
Yeah,
Yes, thank
8,000 feet, 2,400 meters. Yeah.
And so this is one of the reasons why oxygen delivery to the lungs might be, and this depends also then on the cardiac function.
Exactly.
Okay. There are quite a lot of questions still there about equipment use and training of the crews. What about termination of resuscitation? This are quite a lot of questions coming in. Do not resuscitate order, when to stop it, or when to start it. David, any information or any stories on this?
Yep, the termination is also a question that should be discussed with the ground medical crew, and it depends on a lot on the origin of the flight of the company, and also on the landing country, because as Camilla said, this is a real legal issue. What the authors of the articles discussed a lot is the pre-flight check, the medical check. If you have any, or the passengers have any medical conditions that should be considered as a no-go for flight, it should be discussed with the ground medical crew, but it's not happening, to be honest. And people, just imagine the situation, you want to move somewhere or you need to get there, and you will just reach the ground medical crew and said, okay, I have this condition, can I get on board? And said, no, you are canceled from the flight and you are screwed. So that's the point why people will probably not follow this rule in general. But it will be the best thing to know who we have on board and to prevent.
Thank you very much, David. There's a very interesting question that has been mentioned a couple of times around landing. So assuming that you have confirmed cardiac arrest, you have liaised with the base as an on-ground base, and you have agreed that you're going to land, you're going to divert and land. People are doing CPR, multiple people are involved, there's a victim there. Is there any guidance or any recommendation or any evidence to support what we should be doing during landing?
Well, I think it's very, very important to talk to the aircraft crew where we can do the CPR, because during the landing phase, they have to move around. They are not only sitting at their chairs, but they move through the airplane, and we don't want to be in their way and to disturb the landing phase. So we really have to talk to them where we can do the chest compressions and the CPR, and they might advise us. And they can also tell us that we have to stop CPR during the landing for security reasons. And we should adhere to them. So if they tell us, stop it, we need to do this and that, it's not safe if you perform CPR, it might be better to listen to them.
And there is no like restraint system for you providing the CPR. So even the cabin crew needs to be seated, and there is no way how to secure you for the landing in the aisle or somewhere else.
To make the point clear, so the last minutes, maybe what I experience is maybe 5 minutes when they are seated, and then there's no help at all. Is correct?
It can happen. Yeah, it depends on the guidance from and the SOPs of the companies. Yeah.
Good. The simple question, the certification for these webinars, if you write the ERC, you can get something. If you need this for whatever reason, this is the easy part. Specific diagnosis or treatments. A lot of people are mentioning pneumothorax, interventions, liability. I would say, is it correct that it depends a lot what you are able to do and what is feasible?
And what you have in the emergency medical kit,
Yeah.
because it differs a lot. Yeah.
And I would say if in your country, from your medical professional, you wouldn't be allowed to do this or that intervention or to administer this or that drug, don't do it in this situation.
Okay.
100%.
So if
Okay. Sorry, go for it. No, go for it, Tino.
No, I wanted to say so. To sum up all this, so what would be your, Camilla, your recommendation to healthcare providers on a flight? Should I tell people when I'm going into the plane that I'm a physician, or should I still stay quiet in my seat and looking around if somebody else gets up if they call them?
Well, I think if an incident occurs, you might want to help because that's the reason you really got into medicine at all. And if you are in a position where you can't help for whatever reason, that's also okay, because there are bound to be a lot of people with some degree of medical experience. But if you happen to be able to help, please go ahead and help. And as long as you don't accept any money or gifts, the likelihood that you will be under legal protection is quite high.
And getting a better seat, it does not count.
Fantastic. That's a very nice summary and very nice final remarks, everyone. Well, unfortunately, we're coming towards the end of our webinar and we have received over 60 questions. I hope we have managed to cover most of those, but I'm afraid we're running out of time. Actually, having more than 60 questions asked probably indicates one thing, that is a very popular topic and many people would like to chat more about it, and more questions are obviously coming. So if you have any more questions, or if you're really keen to know more about this topic or any other special circumstances, you're more than welcome to join us in Rotterdam later this October in the Resuscitation Congress, where we will be chatting more about the guidelines, the evidence behind the guidelines, and you'll have a chance to interact and connect with people, scientists who wrote the guidelines and other clinicians who will be practicing and implementing the guidelines. And then you can connect with people, ask questions, and explore more about these special circumstances. And another reminder about the next webinar the ERC is holding about Eureka 3, which is European Cardiac Arrest Registry, the third edition, as in the third study. And that will be presented on the 11th of September at 6 p.m. Central Europe time. So if you have not registered for that yet, please scan the QR code and register there. It's free to register and free to attend. And it would be lovely to see as many of you there. Thank you very much for your participation. Thank you, everyone.
Thanks, bye.
Thank you very much.
Thank you.